In this part of the video, we are going to describe the surgery for performing gross wedge resection for a patient who is having globular adenomyosis. For a patient who is having focal adenomyosis, flap surgery or the triple flap, which is commonly called, is one of the best procedures in order to perform the surgery and then perform uterine reconstruction. We prefer not to inject any vasopressin inside the uterus, and the entire surgery is performed with the help of a laparoscopic shearer, keeping it on level L6. L6 involves rapid cutting along with coagulation, and this is one of the best exponents of this device where we are able to perform the adenomyomectomy without significant blood loss. Beginning from the area of the round ligament and approximately 2 centimeters away from it, the wedges are being exponentially cut downwards towards the level of the posterior cervix and anteriorly towards the level of the utrovesical fold. Globular adenomyosis is a disease which causes severe dysmenorrhea in women, and this can be reduced by performing gross wedge resections, which significantly reduces the bulk of the uterine muscle, thereby reducing the thereforward dysmenorrhea which would occur to these patients. It is important to note here that the muscle which is being cut is the diseased uterine muscle, which is grossly adenomyotic. Along the anterior aspect, we are making the cut till the level of the utrovesical fold. Similar steps are also being repeated on the opposite side, and it is very important to note that these patients need to be counseled before the surgery that there could be a compromise in the fertility and future childbearing as long as they are opting for wedge resection. However, there are women who wish to preserve their uterus and are not accepting hysterectomy at any cost, and in such women, especially who are undergoing a surgery for deep endometriosis and have globular adenomyosis, wedge resection is an extremely beneficial procedure and significantly reduces the amount of dysmenorrhea which the lady would encounter in the subsequent cycles. The wedge is cut in a circumferential fashion with the circumference meeting itself along the anterior aspect at the level of the utrovesical fold and posteriorly at the level of the posterior cervix. This would practically divide the uterus and the endometrial cavity into two equal parts in the form of an ice cream cone. Normally, the wedge which is released is taken out of the uterine cavity and the peritoneum with laparoscopic morcellation. This is the same patient in which we performed the surgery for deep endometriosis, and this was a patient who was abandoned 2 times prior, citing extremely difficult surgical exercise. While performing the wedge resection, one has to be careful. We can also use the myoma screw in order to provide the traction at the level of the wedge. However, the assistant providing firm traction with the help of a needle holder is extremely beneficial. The entire musculature is grossly adenomyotic, as you can notice, and in order to cut through the adenomyotic planes, one can use as an alternative the harmonic scalpel, which is an ultrasonic device. However, what we have found in our experiences of performing several gross wedge resections, we think that the laparoscopic shearer is a much faster and a much more cost effective device while performing this procedure. In most of the cases, like in this case, we are able to preserve the endometrial cavity and enough volume of the endometrial cavity can be preserved. This helps the lady in maintaining future function of the menstruation as well. Sometimes one may also opt in order to ligate the uterines at the origin bilaterally before performing the gross wedge resection, which would significantly reduce the blood loss in these cases. However, as you can notice, with the help of the shearer, the amount of bleeding is next to minimal. The wedges are then ploughed down till the level, as described before, till the level of the cervix on both the sides. Firm traction is being applied by the assistant in order to see to it that the wedge is taken out from the margins of the uterus. We initially finish coring the wedge till the depth on one side, Then we move on to the other side, and exactly same steps of wedge resection are performed even on the opposite side. The most important key here is to perform good traction, because the wedges are pretty bulky and the adenomyotic tissue otherwise could be a very nasty and a difficult tissue to cut. Importantly, one must note that one must not leave behind too much adenomyotic tissue, because otherwise suturing the adenomyotic uterus with lot of adenomyotic tissue being left behind is an extremely difficult exercise in itself. It is important to note here that when we are suturing the uterus following a gross wedge resection, the barbed sutures are the best sutures because they help in holding the uterus together much more efficiently as against the normal uterine sutures. You can see the gross wedge has been taken off, the uterine has been split into two, and now the resuturing or the reconstruction of this uterus will begin, where we will be passing barbed sutures from one corner to the other corner. We typically like to perform the suturing in two layers. The deeper layers are cored through the adenomyotic tissue. We do not like to perform baseball sutures in such situations. It has been our experience that routine sutures, which are continuous sutures, are much better than baseball sutures, especially in cases of adenomyotic uteri. You will notice that the uterine tissue is extremely difficult to manipulate, and when the uterine tissue gets difficult to manipulate, it could be a wise option to chop off the round ligament on both the sides like we have done in this case, which further adds to the mobility of the uterus and makes the suturing and approximation slightly more tension free as against the routine cases. Releasing the round ligaments would also help in relaxation at the level of the sutures, which would enhance the healing of the uterus. As I have already spoken before, women should be counseled to not become pregnant following the gross wedging, because the chances could be high for uterine rupture. These are the women who typically do not want to undergo a hysterectomy, could be slightly younger, have already had children, but wish to preserve their uterus for the sake of womanhood. These women would normally continue to menstruate just like any other woman on a month to month basis. However, the frequency would reduce because of the coring of the endometrial cavity which has occurred while performing this surgery. We usually like to take one entire reel of barbed suture along the anterior margin with a second reel of barbed suture along the posterior margin, and then we like to tie both the barbed sutures to each other so as to prevent the sutures from slipping away. There are various forms and applications of barbed sutures which are available from various companies, and a surgeon may choose to decide and use the things which he or she is most comfortable using. Because the tissue is adenomyotic, we like to use a cutting needle in order to perform the sutures. As you can see, most of the sutures which you are seeing are being performed in real time without much editing. You will also be able to notice that the margins of the sutures are not so healthy because of the gross adenomyosis which the uterine tissue presented with. We like to use a suprapubic port in order to perform the laparoscopic suturing, and you will be able to notice that suprapubic port has tremendous advantages, especially in suturing of the uteri in such cases. It is extremely ergonomical, especially for people and surgeons who are short in height like how I am. Similar sutures are then drilled through the posterior aspect in an exact same fashion, starting from the posterior cervix ending at the level of the fundus of the uterus. The last suture is burrowed inside the adenomyotic capsule so as to prevent it from slipping out from that end. You will be able to notice that because of the laparoscopic shearer which has been used in order to perform the adenomyomectomy, the amount of bleeding is extremely negligible in such cases. This is the unedited version of the sutures which we are demonstrating through the suprapubic port, and you will be able to realize how ergonomic it is for people who are short statured to perform suturing with the suprapubic port. We use the barb sutures having needle at both the ends, and one can proceed with suturing in such cases in the form of a typical shoelace fashion, where the deeper layer and the upper layer are both simultaneously taken, and at the end the suture strings are pulled together so as to tighten the tissue. The last 5 minutes which we have been watching for the video are an unedited part of the video where we wanted to demonstrate the suturing with barb sutures with needle at both the ends in cases of gross wedging. Similar sutures are then drilled through the posterior aspect of the uterus, as you can notice, starting at the level of the cervix in two layers, the deeper layer and the outer layer, which are both taken simultaneously. Again, the suprapubic port is being used here, and as you can notice, you will have now realized how significantly the size of the uterus has gone down thanks to the wedge resection as compared to the previous bulk which was visible in the part 1 of the video or at the start of the video. These two suture ends are then looped and tied together so as to prevent the slippage of the suture from any part. This keeps the tissue in place. We prefer not to use any adhesive barrier in order to prevent adhesions at the end of this suturing. The adenomyotic tissue is taken out with laparoscopic morcellation.